in welcoming you all for the IPNA Endorsed Webmaster Series 2020. Today, we have three eminent speakers, and the moderator of the day is Dr. Edwin Fernando, who is taking little time to join. The first speaker of the day is Dr. Aruna Rajendran. Dr. Aruna Rajendran is a consultant at VS Hospital. She is a pediatric hemato-oncologist and bone marrow transplant physician. She is an assistant professor at Department of Pediatric Hematology at Institute of Child Health, Chennai. And she is a lead bone marrow transplant physician at VS Hospital, Chennai. Her specific academic interest is towards hemophagocytosis and immunology of bone marrow transplant. She is also received Best Poster Award in the year 2012. She has received ICMR travel grant and also a fellowship grant from Hyundai Motor Foundation and Dana Fiber Global Health Program sponsored by BMT Training. And it is a pleasure to welcome Dr. Aruna to go ahead with the topic. Over to Dr. Aruna.
Thank you, madam. Thanks for the nice introduction. I thank the organizers for giving me this opportunity to talk on a very interesting topic in today's evening. So the topic is the Nephro perspective in pediatric hemato-oncology. So I know very little nephrology. So whatever is related to my topic of my specialty, I'll be discussing today. Some topics you may know better than me. So some things I may add to what, especially more on the hemato-oncology aspects. So with this, let's go through the top. So there's going to be around 35 slides we'll discuss in the next 25 minutes. So we'll talk on these topics today. So the renal issues in pediatric hemato-oncology. So often we see renal issues at the time of disease presentation, which can be just a primary renal neoplasm, or it can be diseases which affect the kidneys, malignancies, systemic malignancies like leukemias, lymphomas, which affect kidneys as a part of the disease. During therapy, we do see a lot of infections. So the infection sometimes originates primarily from the urinary tract, or with primary the urinary tract, it may still go on to the other organ, like it can present as a systemic bacteremia. We do see fungal infections involving the kidneys and by the viral, especially which involves the bladder. And we'll also go through the drugs, chemotherapy drugs and supportive care drugs, which can affect the renal parameters, and the common electrolyte imbalances which are seen during therapy, and the acute kidney injury issues during the time of transplant, benign hematology. And a few words on the long-term therapy-related renal effects. So maybe this is the way, which is how we see nephrology. We see as pre-renal, renal, post-renal. So pre-renal is when a patient is volume depleted state, chemotherapy-induced nausea, vomiting. We often see pre-renal type of issues in these children. And we can see when they have third spacing, capillary leak syndrome, as seen in bone marrow transplant. Hepatic veno-occlusive disease is a type of capillary leak. And so in these cases, we predominantly see pre-renal type of renal manifestations. And when we use nephrotoxic chemo drugs, when we expose them to contrast agents, when by chance they are on NSAIDs, which is very unusual in hematology patients, and when we see tumor lysis syndrome, disease infiltrating the kidney. So all these causes are going to affect the kidney. And rarely we do see post-renal tumor compressing the ureters and causing obstructive uropathy. So when we go through a few slides on primary renal neoplasms, as we all know, in children, the most common kidney malignancy is Wilms tumor. It's one of the very nice tumors to treat. And whenever a child comes with a renal malignancy, there's a 90% chance it's going to be a Wilms tumor. We do get to see other tumors like clear cell sarcoma, malignant renal rhabdoid tumor, occasionally renal cell carcinomas, but these are much less in number as compared to Wilms tumor. I have never seen a renal medullary carcinoma, but renal medullary carcinoma is known to occur in patients with sickle cell trait, predominantly being described among the Africans. with sickle cell trait. And synovial sarcoma of kidney, we have seen 2 cases in the last few years, and they are all rare malignancies which affect the kidney. Whenever a baby presents, an infant who is less than 6 months, and he is going to present with a cystic lesion in the kidney, often benign causes overrule the malignant causes. So we do see mesoblastic nephroma. Actually, that is a solid tumor. There is cystic nephroma, cystic partially differentiated nephroblastomas. These are just, they are not as, it's not, maybe some are intermediate malignancy, but most of them are just treated by a nephrectomy. So this is a 4 months baby. He presented with, the baby presented to the outpatient department because mother noted incidentally detected abdominal mass. Baby did not have any hypertension or hematuria. It was a well-thriving child. CT abdomen showed, we can see areas of solid tumor and also few cystic areas involving the entire left kidney. As we see the images over here in the below the second panel of images, we can see the right kidney being pushed and the mass is actually crossing the midline and the vessels are intact but pushed to the opposite side. So with this picture, which as we discussed in the previous slide also, often a child between 1 to 5 years, we think of Wilms tumor, but as the baby is just 4 months old, the child underwent upfront nephrectomy and the histopathology was suggestive of congenital mesoblastic nephroma cellular type. So when we go through Wilms tumor has extremely good prognosis. The 5-year survival is more than 90%. Yeah, a stage 4 Wilms tumor, which affects the lungs, which is spread to the lungs, liver, they still have a survival of around 50 to 60%, unlike other stage 4 tumors. So it often presents as an incidentally detected abdominal mass. It can be associated with hypertension in 25% of the cases, hematuria in 12 to 15%. And the age group is often age less than 6 years and peak age of 2 to 3 years. It is treated with chemotherapy and surgery. Whenever it is a stage 3 or stage 4 tumor, those children also get radiation to the abdomen plus or minus the lungs in a stage 4. So clear cell sarcoma, it is also once called as the bone metastasizing renal tumor of childhood. The age group is similar to Wilms. The radiology often resembles Wilms, and whereas the histopathology is it helps in differentiating clear cell sarcoma from a Wilms tumor. It is treated with intense chemo with than Wilms tumor and also will require radiation. So renal cell carcinoma, this is the typical triad of pain, abdomen, hematuria, and renal mass seen in adults. And children may or may not have this triad. And it is seen predominantly older children, more than 10 years of age group. When it happens in childhood renal cell carcinoma, it may be associated with von Hippel-Lindau syndrome. So the previously described benign tumors like congenital mesoblastic nephroma, all these are treated only by nephrectomy. In this slide, this set of CT abdomen, we can visualize again a mass. It is difficult to say whether the mass arises from the upper pole of the kidney or not. But actually, if in 2 images, we can see the kidney being pushed downwards and laterally, inferiorly and laterally. So this is actually a suprarenal mass caused by neuroblastoma. So the closest differential diagnosis for Wilms tumor is neuroblastoma. We can often see a big intact kidney in at least few of the images, unlike Wilms tumor. So there are other malignancies which can have renal involvement as a part of the disease presentation, especially leukemia. So leukemia acute, usually it is the ALL, acute lymphoblastic leukemia, and lymphomas, which is usually lymphoblastic lymphoma, which often presents with tumor infiltration, and the kidneys become enlarged, they have renomegaly, and they may have hypertension. So in autopsies, this is not as a presentation. In autopsy in adults, it has been shown that 60 to 90% of leukemia patients, 90% of lymphoma patients have some component of renal involvement. And this renal involvement can be appreciated in imaging as enlarged kidneys with multiple hypoechoic lesions in ultrasound and even in CT scan, CT. And other form of renal involvement that is seen during leukemia, either at the time of diagnosis or immediately after treatment initiation, is the tumor lysis syndrome. I will go through tumor lysis syndrome in detail. And the other tumors are pelvic germ cell tumor can cause obstructive hydrocephalus and obstructive hydroureteronephrosis, and bladder wall rhabdomyosarcoma can present as either a mass, pelvic mass, or it can present with hematuria. So this 9-year-old male, he presented with history of 2 months history of pain abdomen with recurrent vomiting. He had actually lost 2 kg weight in this period. He's thin built. At presentation, he was sick looking with a heart rate of 200 per minute. He was tachypneic and BP on the higher side of 130/80 with saturation being maintained. Per abdomen, there was a vague mass palpable in the umbilical area measuring 10 into 12 centimeter. So this is ECG at the time of presentation in ER. So we can appreciate that there is a tachycardia and a monitor showing a heart rate of 208. And we can also appreciate the ECG finding of tall tented, tall peak T waves, which is taller than the R wave or almost equal to the R wave. And this is actually caused by Burkitt's lymphoma. The Burkitt's lymphoma often has the tendency to present as tumor lysis syndrome even without treatment. So this is one of the worst oncological emergency that is an established tumor lysis syndrome. So his potassium was 6.5 and his uric acid was 11. Calcium was, there was hypocalcemia. Phosphorus was on 6.7 high. And he was already going into early renal injury with urea of 45 and creatinine of 1.2. His counts were normal. So what is tumor lysis syndrome? It is an acute metabolic derangement caused by sudden or rapid breakdown of tumor cells. And classically, the intracellular ions are released and the patient has hyperkalemia, hyperphosphatemia, hyperuricemia. And as a compensatory mechanism for the hyperphosphatemia, the calcium drops. So hypocalcemia, along with when there is a component of renal injury, we do see metabolic acidosis with azotemia. So it can be therapy related and sometimes spontaneous. So the therapy-related tumor lysis syndrome actually happens within the first week of therapy initiation in leukemia lymphomas. As it is mentioned, high-risk tumors for tumor lysis are actually leukemia and lymphoma. Leukemia, especially when the WBC count is more than 1 lakh, but even if the WBC count is low, leukemia actually it involves every bone of the body, every marrow within every bone. So for a 10 kg child with leukemia, the bone marrow may weigh something like around a kg, 1 kg. And we can think that within a week's time, the marrow of 1 kg is going to lyse with steroid or chemotherapy initiation. So, and the low-risk tumors are often solid tumors. Wilms tumor, neuroblastoma, rhabdomyosarcoma have very, very low potential to develop tumor lysis. Sometimes we do see solid tumor like germ cell tumor going for tumor lysis syndrome, especially when they have an obstructive uropathy component. So this diagram on the left says how the high uric acid happens during tumor lysis. So when cells are breaking down, DNA degrades into like hypoxanthine and xanthine. And hypoxanthine and xanthine are soluble to some extent. Whereas uric acid also is a soluble component till it reaches a high level, especially in the scenario of tumor lysis. We have a high load of uric acid to be excreted and becomes insoluble. And in birds, uric acid gets converted to allantoin with the enzyme urate oxidase, which is not present in humans. In humans, the end product is uric acid, whereas in birds, the end product is allantoin. So RAS buricase is the recombinant urate oxidase enzyme. This converts uric acid into allantoin when the patient is given this as a drug. And when we use allopurinol, this inhibits xanthine oxidase and prevents the conversion of hypoxanthine and xanthine into uric acid. So this is how allopurinol and febuxostat both act. So this table on the right says about how tumor lysis syndrome is classified. We call it laboratory tumor lysis syndrome when we are just having biochemical abnormalities. When we call it clinical tumor lysis syndrome, when one of the end organ is involved. One of the end organ is like there are 3 end organs: kidney, cardiac, and CNS involvement. So if any one of this gets manifested clinically, we call it clinical tumor lysis syndrome. We always prefer to treat when it is just a biochemical or there is no tumor lysis. We like to prevent it rather than treat a well-established tumor lysis syndrome. So the predisposing factors are tumors which are having high chemosensitivity like leukemia and lymphoma and have otherwise also a high cell turnover. The classic examples are leukemias and lymphomas. Large tumor volume in a small child are more prone for tumor lysis. And when we have hyperleukocytosis and we have a big node, big liver and spleen, they are more prone for tumor lysis. A host in a small child having a large tumor, volume depleted state, making the patient more prone for renal injury. And in infants where we have unpredictable intake and sometimes difficulty in measuring the urine output. So all these host factors makes a patient more prone for tumor lysis. And when we are going to co-administer nephrotoxic drugs, we can understand a child who is coming with a pelvic mass and we are doing a CT abdomen with contrast, we are going to increase the increase the risk for renal injury. Similarly, when patient gets, when a hospital uses piptaz amikacin as the frontline drug for oncology patients, when they present with fever, again, use of amikacin may increase the risk of renal injury. Similarly, when patient is having a tumor which is infiltrating the kidney, tumor causing outflow obstruction, and even in tumors which are not known to lyse fast, but they are exposed to very highly targeted effective drugs, as rituximab for sometimes even for Hodgkin's lymphoma can lead to tumor lysis. So how to manage a tumor lysis syndrome child? It is very important to identify a high-risk patient. Give hyperhydration and allopurinol are the major steps we take to prevent tumor lysis. Hyperhydration is something that we give a fluid around 3 liter per meter square per day. The fluids are often normal saline or normal saline plus dextrose. And along with that, we use allopurinol with a dose of 10 mg per kg per day. And adults often use febuxostat instead of allopurinol. In pediatrics, we prefer to use allopurinol. I don't really know a specific reason for that. And rasburicase is a drug which has almost avoided the progression to a full established renal injury after its availability for the last at least 15 years. The dose of rasburicase is variable. Often we limit it to a single vial for a child for a single day. Though it can be used up to 5 days in OD dose, so we have had very less requirement to use in such a way. And whenever we use rasburicase, it is important to send the lab samples in ice because it has an ex vivo activity and we may get falsely low uric acid levels. And we have to maintain a strict intake output chart. We are going to hydrate the child. We target a urine output of more than 2 ml per kg per hour. Patient should be on continuous ECG monitoring to identify the dynamic changes in potassium. And they undergo regular, frequent intervals, electrolytes, RFT, uric acid, calcium, phosphorus monitoring, again to identify early biochemical changes. And the specific electrolyte imbalances are managed. I'm not going to discuss about that. And there should be a very less role for renal replacement therapy. That is the primary goal in TLS management. So when patient goes for renal replacement therapy, we expect a high mortality because we can understand a leukemic child's platelet count may be 10,000. To insert a dialysis catheter itself becomes a high-risk procedure in such. So once upon a time, soda bicarb was used as an important drug during TLS management. And now we refrain from using soda bicarbonate, because when we increase the urinary pH from 5 to 7 by using soda bicarb, it definitely increases the uric acid solubility. But actually, calcium phosphate starts crystallizing in the urine and ends in worsening the renal injury. So further, we all know hypocalcemia as a part of tumor lysis. Using soda bicarbonate exacerbates hypocalcemia. So we use soda bicarbonate in the setting of hyperkalemia during tumor lysis management, but otherwise we do not use it routinely. So so as we understand, tumor lysis syndrome has now become is predominantly now being managed with predominantly by oncologists with occasional involvement of nephrologists, just because by using hydration and with uricosuric drugs. But still, we do call them at least once a year when a child with established renal injury. And infections, we do see a lot of, we'll go through the topic of infections in hemato-oncology. We do see UTI, which are sometimes symptomatic, most of the times asymptomatic, done as a part of febrile neutropenia evaluation. And more organisms, as we see these children are hospital associated, they do develop healthcare associated infections like multi-drug resistant Klebsiella, E. coli, and it can sometimes lead to bacteremia in these children. And along with bacteremia, we do see AKI as a part of multi-organ dysfunction. So this 12-year-old male, he presented with fever, nausea, vomiting for 1 week. He was noted to have hypertension and palpable right kidney. Blood parameters revealed actually normal counts. His urea and creatinine were high at presentation. And in view of this acute kidney injury, he underwent a renal biopsy, which actually showed mucormycosis. Blood sugars were normal. HIV ELISA was non-reactive. He was treated with amphotericin along with hemodialysis. So 2 months later, when he was followed up, he presented with a new onset oral ulcer with palatal perforation, and biopsy again showed mucormycosis involving the palate. He had by this time developed thrombocytopenia, and bone marrow showed ALL. So his diagnosis was ALL presenting with disseminated mucormycosis front. So we do see mucormycosis during therapy at presentation. Sometimes it even precedes leukemia by a few weeks before actually leukemia is overtly manifested. So fungal infections, which we see affects the kidney, are mucormycosis and candidemia. So mucormycosis, isolated renal involvement sometimes, or renal involvement as a part of systemic mucormycosis. And it can present as AKA, requiring renal replacement. It is definitely a tough fungus to treat, because it responds in some way it responds to amphotericin, but not in a complete, like ampho may not be able to completely reverse the status. We need the neutrophils back for the child to recover. And in places where it can be debrided, like if it is in the sinus, surgical debridement helps in controlling the fungus. Candidemia is seen as a part of, it can sometimes present with AKI, and we can see some fungal balls in the kidneys. And we treat candidemia in candidemia, we prefer, actually it's written as amphotericin, but preferentially we use cascofungin as the drug of choice. In viral infections, it predominantly manifests in the manifestations are involving the bladder as hemorrhagic cystitis. And in the setting of stem cell transplant, we see BK virus and adenovirus affecting the bladder and manifesting with hematuria. And we see the drugs which affect the kidney, chemotherapy drugs. We can divide them into two: kidney toxic or bladder toxic. The kidney toxic drugs are methotrexate, cisplatin, ifosfamide, whereas bladder toxic drugs are predominantly cyclophosphamide and ifosfamide. So bladder toxic drugs often manifest as hemorrhagic cystitis. And nowadays it is very, very less in incidence with use of mesna and hydration along with these drugs. So among the renotoxic drugs, cisplatin, which is used in germ cell tumor, hepatocellular carcinoma, and in neuroblastoma treatment. It is both a nephrotoxic and ototoxic drug. It is a highly emetogenic drug, often leads to a volume depleted state if emesis is not controlled. It can cause tubulointerstitial injury, and it predominantly the renal injury manifests as polyuria, hypomagnesemia, hypokalemia as electrolyte imbalances. So we prevent renal injury due to cisplatin by hyperhydrating the child along with mannitol to create an osmotic diuresis. Amifostine is capable of protecting the patient from cisplatin-induced nephrotoxicity, but in children it is not used much because there are some evidence of amifostine causing less cisplatin activity, like the effect of cisplatin also gets dampened. So it is not used much in children. Magnesium supplementation is very important because to avoid hypomagnesemia. There are also some reports of magnesium supplementation attenuating renal damage in murine models. Similarly, methotrexate is again both a hepatotoxic and nephrotoxic agent. It is an antifolate drug. It inhibits dihydrofolate reductase. The dose is very variable. Actually, we use sometimes a dose of 10 mg to as high a dose of 12 grams per meter square as in osteosarcoma. It is also used in leukemia lymphomas. So we see nephrotoxicity when the dose goes above 1 gram per meter square. And we avoid the nephrotoxicity by hydrating the child along with use of soda bicarbonate with a target urinary pH of 7.5. So we pre-hydrate the children for 12 hours prior to this dose of methotrexate, dose which crosses above 1 gram per meter square. And we monitor drug levels of methotrexate can be done and done at 24 hours, 48 hours, and 72 hours. When the drug levels are high, it is again counteracted with usage of folinic acid. So leucovorin rescue, folinic acid is also known as leucovorin. The usual dose is 15 mg per meter square per dose, but the dose as high as 100 mg to 1 gram per meter square doses are given if patient develops nephrotoxicity. It is a protein-bound drug, often not dialysable. And again, monitoring drug levels and using folinic acid helps in preventing the nephrotoxicity. Ifosfamide is cyclophosphamide affects the bladder alone, but ifosfamide is capable of causing renal injury also. It can cause neurotoxicity also. So it is a drug which creates something like a Fanconi syndrome in the kidney with proximal tubular dysfunction. Again, causes potassium and magnesium wasting. The dose, when we reach a high cumulative dose, the nephrotoxicity is more prominent. So usage of combination chemotherapy, nephrectomized children are more prone for developing ifosfamide toxicity. So gemcitabine, this drug is used predominantly as salvage drug in pediatric oncology, whereas in adult oncology and adult hematology, it is often used upfront also. So this can cause nephrotoxicity by inducing thrombotic microangiopathy, and we will see it in the future slides. So thrombotic microangiopathy, it can be because of the disease, it can be because of the therapy, or it can be a part of stem cell transplant. So patient typically has anemia and thrombocytopenia. Anemia is classically a microangiopathic hemolytic anemia. So these microangiopathic hemolytic anemias are going to have fragmented RBC in the smear, increased LDH and hyperbilirubinemia. But sometimes we do not have anything of this, but still the patient may have a thrombotic microangiopathy. And anemia and we live with anemia and thrombocytopenia throughout our life. So how to differentiate myelosuppression, chemo-induced myelosuppression from TMA? So these factors should alert a physician, that is appearance of hypertension, new onset or worsening of hypertension, proteinuria, or and we know that the drug is known to cause TMA, usage of such a drug, and partial or complete recovery after drug withdrawal all supports TMA when we do not have biochemical or hematological evidence. And treatment, if the withdrawing the drug often helps in recovering from renal injury. Sometimes patient ends up getting plasmapheresis, steroids with FFP transfusion. Rarely we have used rituximab, and we have never used eculizumab for this indication. So these drugs are known to induce TMA, gemcitabine, cisplatin, the anti-VEGF, bevacizumab, cyclosporin, and tacrolimus. So there are different type 1 thrombotic microangiopathy and type 2. So this is something new for me. I learned it while making this presentation. So what I understand is type 1 thrombotic microangiopathy often leaves residual renal damage, and it is much more serious than type 2, whereas type 2 is often reversible. So most of the drugs that we talked about, gemcitabine, cyclophosphamide, cisplatin, all of them are going to cause type 1 injury, whereas anti-VEGF and other targeted drugs cause type 2 thrombotic microangiopathy. The other problems that we keep on doing images to know what is happening to the tumor. So the contrast-induced nephropathy is something we often fear. So it is seen in patients who get intravascular iodinated contrast. When they have underlying renal injury or the patient is in volume depleted state, when we are going to co-administer nephrotoxic drugs, patient is more prone. So how to prevent it? Limiting the contrast volume, pre-hydrating the patient with normal saline, discontinuing or avoiding nephrotoxic drugs pre and post contrast. And sometimes, occasionally, we have used N-acetylcysteine. So we do our oncology textbooks, and sometimes practically also we monitor drugs like carboplatin and busulfan. Actually, busulfan in the setting of stem cell transplant, and carboplatin for the solid tumors. So our supportive care drugs can also be nephrotoxic. These are the common drugs that we use can cause nephrotoxicity: amikacin, vancomycin, colistin, fosfomycin. We are a big fan of Septron, and we use amphotericin very liberally. And these drugs sit forward in the setting of stem cell transplant in acyclover, which can cause acyclover stones, with especially in a volume depleted child, or the other supportive care drugs which can cause nephrotoxicity. So this is a 6-year-old girl. She was brought with complaints of polyuria and polydipsia. Actually, the mother did not give importance for the soft tissue swelling, which was there for 2 to 3 years over the right frontoparietal region, and it also had irregular bony margins. So we can see a punched out lesion in the skull X-ray, and the MRI showing a soft tissue component within the punched out lesion. And her sodium was on the higher side, 148. Potassium was okay. Her serum osmolarity was higher than the urine osmolarity. So she was diagnosed to have Langerhans cell histiocytosis, presenting as diabetes insipidus. So we often call nephrologists when we have difficulty in managing electrolytes. So SIADH presents as, it can be a toxicity due to drugs like vincristine, cyclophosphamide. Diabetes insipidus we see in the setting of LCH. Hypokalemia is a major problem when we use amphotericin, and also the drugs that are mentioned to cause hypomagnesemia do cause hypokalemia. So chemo drugs like cisplatin, ifosfamide, and amphotericin are all the, so whenever we have refractory hypokalemia, or daily we are supplementing 3 to 4 to sometimes 6 milliequivalents per kg, 6 milliequivalents per kg of potassium per day, and still it's not corrected, we keep hypomagnesemia as a cause for refractory hypokalemia. And we do see metabolic acidosis with prolonged usage of amphotericin. So the 6 months baby, she was diagnosed with infantile fibrosarcoma of the left arm. She underwent upfront total excision, near total excision of the tumor. She was started with chemotherapy, vincristine, actinomycin, and cyclophosphamide. On the first week, day 5 after chemotherapy, she was brought with 1 episode of seizure, and her serum sodium was 120. She was given a bolus of 3% sodium chloride. Mother also complained of hoarseness of voice. Actually, she complained of decreased volume of cry. So this was the vincristine toxicity. Actually, in older children, vincristine commonly toxicity presents as constipation. In adults, as peripheral neuropathy. Whereas in infants, we see unusual manifestations like SAADH, hoarseness of voice. We see ptosis as side effects of vincristine therapy. So in the setting of bone marrow transplant, it is slightly different because the drugs are slightly different. Otherwise, actually the drugs like busulfan, cyclophosphamide, alkylating agents can cause renal injury, cisplatin, carboplatin used in conditioning, radiotherapy given as a part of total body irradiation. During post-transplant period, patient receives calcineurin inhibitors for a period as short as 6 weeks to as long as even 2 years. So again, these drugs can cause nephrotoxicity and as we discussed, thrombotic microangiopathy in the previous slide. Amphotericin also antifungals are given very liberally during transplant. And when we use DMSO as a cryoprotectant, there is a component of red cell destruction within the bag in cryopreserved products. And when we re-infuse it to the patient develops intravascular hemolysis related renal injury. Patients do have volume depleted state during transplant, both as vomiting and diarrhea as a part of mucositis. They do develop sepsis, especially in the setting of severe neutropenia. And we have other capillary leak syndromes like all these can be as a part of endothelial injury, that is graft versus host disease, the TMA, sinusoidal obstruction syndrome. They are all maybe a different manifestation of the endothelial injury, and often there is a component of renal involvement. So we do see acute kidney injury even in benign hematology. So, and there's this is a common scenario to see G6PD deficient child presenting with intravascular hemolysis and pigment nephropathy. We also see sometimes proteinuria in inherited megaloblastic anemia as a part of the scubum receptor defect and Emerson-Grisbeck syndrome. In sickle cell disease, renal involvement is a major part of disease manifestation. We also saw in the previous slides that they do develop renal medullary carcinoma. The iron chelators that we use during as a part of hemolytic anemia, transfusion-dependent hemolytic anemia management, defersirox can cause asymptomatic urea creatinine elevation. So we keep monitoring RFPs in these patients. Hematuria is a manifestation in children with bleeding disorders like ITP, and then diseases like hemophilia. They can present with hematuria. Thrombotic thrombocytopenic purpura hemolytic syndrome is co-managed with nephrologists and hematologists. So, and SLE, we see a huge overlap of hematological and nephrological manifestation in a patient. Patients come with Evans syndrome, antiphospholipid antibodies, along with renal involvement. So we can see even after a patient completes treatment in a patient oncology child, he may have a long-term hypomagnesemia when he is given drugs like ifosfamide, cisplatin. Renal functions also need to be monitored when such nephrotoxic drugs are used. In nephrectomized children, there is a risk of, in Wilms tumor, when they have an opposite normal kidney, the risk of renal failure is very, very low. It's 0.25%. This risk increases in the presence of underlying Dennis-Rash syndrome or when the child has underwent abdominal irradiation. And we should monitor these children for blood pressure. We should avoid excess weight gain in these children. Their renal function should be monitored and urine should be monitored for proteinuria. So this proteinuria happens as a compensatory phenomena of the normal kidney undergoing hypertrophy and hyperfiltration injury. So we come to the end of this presentation. As we understand, there is a bidirectional relationship between cancer and kidney disease. The AKA in cancer has often patient has increased morbidity and it may also lead to increased mortality. A multidisciplinary approach, early interventions to avoid life-threatening AKI is important in patients with cancer. So this is maybe an important subspecialty, onconephrology, and it has a huge scope for work, research, and understanding.
Thank you, Aruna, for the wonderful talk. Very comprehensive.
Thank you, sir.
As you rightly said, onconephrology is our upcoming subspecialty of nephrology. You mentioned about tumor lysis syndrome and treatment with allopurinol. Have you seen any bad skin reactions with allopurinol in this group of patients?
Oh, no, sir.
Because there's some HLA association and skin rashes caused by allopurinol, where febuxostat is a better drug to treat these patients, number one. Number two is, when you use rasburicase, what's the time interval you see the uric acid levels come down?
So usually, so regarding allopurinol, I have never seen skin rashes in children, but I have never used allopurinol in adults. I don't know why. Because adult oncologists have always used febuxostat. I've also stuck to it. It's something interesting, sir. I will also go through it. And rasburicase, we usually send a repeat sample after maybe 8 to 12 hours after giving the drug rasburicase. The uric acid levels are monitored after 8 to 12 hours, sometimes around 24 hours. The next day, we do it just to see whether we have to give the next dose. And we see a dramatic drop in uric acids. So the dramatic drop has to be always ensured because the sample is not processed immediately. And if it lies in the lab for 6 to 8 hours, we can have a false low uric acid levels.
The other point of interest in onconephrology is the use of immune checkpoint inhibitors. There has been a lot of talk about these immune checkpoint inhibitors. And if you look at the nephrological side effects of these, it ranges from any glomerular disease that you mentioned up to acute interstitial nephritis. So this is something that that needs to be looked into because these drugs are widely available in the Western world. Maybe shortly we should be, I do not know whether it is really available here or is it available? These drugs, are they available?
Yes, sir. These drugs actually can be procured on one-to-one basis, sir. So it is used in refractory diseases. We use it.
Okay. The other thing is the chimeric.
Yes, sir.
Chimeric antigen receptor therapy used in acute lymphoblastic leukemias. Again, a cytokine-like syndrome and acute kidney injury secondary to acute interstitial nephritis has also been described with this group of drugs. I don't know, again, whether this therapy is available in this part of the world.
So CAR T-cell is not available in India currently, sir, but I have been in centers which provide CAR T-cells, and definitely it is a very traumatic period to undergo, but it is like all or none phenomena. If they come out of CAR T-cell therapy, they are also disease-free. It leads to such a big cytokine storm syndrome. So say, sorry, it is a very tough time for the patient, and almost all organs, especially the brain, gets affected.
So,
there's a question whether.
Yes, please. Prabha, madam, you want to say something?
Do we do G6PD levels before giving rasburicase? So the textbook says we should do G6PD levels, but we have never done G6PD levels. And till now, fortunately, we have not seen a patient having an IV hemolysis, like intravascular hemolysis following rasburicase administration. But in population where G6PD deficiency is very dominant, sometimes actually in North India, we see more G6PD deficiency than South India. If feasible, we should get a G6PD level, but this drug is often given on emergency basis. So I think more caution rather than the levels which will help in managing the patients.
The group of people from Rajasthan and Gujarat who stay in this part of the city, like Saukarpet, so probably you must keep in mind this group of patients because they are the ones that have G6PD. We have seen a lot of patients who come from our area to Stanley who have G6PD deficiency, which gets precipitated by primaquine therapy or chloroquine therapy. So this population, I think you must keep it in mind when you give rasburicase or any other drug that can cause hemolytic crisis.
Okay. I wanted to just know, following bone marrow transplant, what antibiotics are given?
Sorry to interrupt. We'll take the questions towards the end of the session, ma'am, because Aruna madam also has read out the question and she has answered to the question. We'll take the questions towards the end of the sessions.
Okay.
Is that fine?
Thank you. Thank you.
Yeah, that's fine. That's fine.
Thank you, sir.
Thank you.
The next speaker, sir.
Yeah.
Yeah, sir. So you're able to see Dr. Prabha Madam through these slides, sir?
Yes. It's my pleasure to introduce Dr. Prabha Senguttuvan, who is MD in Pediatrics and DM Nephrology. She has been one of the pillars of pediatric nephrology in the country and also at the Institute of Child Health at Chennai. She has special academic interest in early detection and antenatal intervention in CACUT. She's been the recipient of ISN Fellowship Training Awards 86 to 1988, an Outstanding Women's Award by the Tamil Nadu Dr. MGR Medical University, and Merit Award for Academic Excellence in Publication by the Sri Ramchandra University in 2014. So Madam will be the chairperson for this session. Do I introduce Amish also?
No, sir. Like once Prabha Madam session is over, you can introduce Dr. Amish.
Okay, fine. Okay.
Thank you so much.
Next.
Prabha ma'am, you're there?
I'm there. How to move the slides?
Like you can use your keypad, ma'am, to move your slide.
Keypad.
Yeah.
Hey. Cursor I can use?
Yeah, cursor to click on to the next, ma'am. Just go and tap to the next, your slide would move forward.
Yes. Okay, now we will move on to a lighter topic, discussing about the psychological challenges in children. Children with end-stage renal disease undergoing regular dialysis suffer from various health problems, either from the disease per se or due to the therapy. Dialysis treatment has evolved to enable children to live longer and transit to transplantation. Children with end-stage renal disease under maintenance HD suffer continuously from stressful health problems due to psychosocial stressors such as loss of independence and social stigmata and bill burden and depression. This adversely affects their life. So I'll be focusing mainly on psychosocial functioning, quality of life of the children. So psychosocial assessment of the patient is critically important because there is a growing evidence that the psychosocial status of the patient impacts the medical outcomes. And number two, object of the therapy is to maximize their quality of life. So let us go through the physical and psychosocial status. Physically, they may be having growth failure, diet and fluid restrictions, and they cannot take their favorite foods like dark chocolates, which is high in potassium, and dairy products, which are high in phosphorus. And psychosocial status, mainly emotions and behavior. Initiation of hemodialysis is felt as a punishment by God, and hiding diseases from others, practicing religious obligations, and they don't know what their future plans are. So what are the psychosocial problems? Depression, anxiety, withdrawn states, somatic complaints. And other problems are irritable states, worry, anger, aggression, disruptive and intolerance to rules, whims and excessive demands. And finally, it affects even the quality of sleep, impaired quality of sleep and sleep stabilization. So the first and foremost is the depression. How do you define depression? Depression is defined as by DSM-5 is defined as subjective repressed mood every day with reduced interest in activities over a 2-week period presenting with any of the following. It could be weight loss, insomnia, psychomotor agitation or retardation, fatigue, feeling of worthlessness, recurrent thoughts of deaths. So half of the CKD patients, nearly 44%, suffered from depression. Low serum iron levels was supposed to be associated with depression. So if they have a self-assessment of health, poor high schooling, good high schooling, normal blood sugar, blood glucose levels, they had a good correlation with absence of depression. So what are the causes of depression? One is mainly the underlying disease. The other is poor nutritional status where these people children have anorexia, non-adherence to medications and self-care, and immunological dysfunction leading on to depression. And this adds on to fluid overload and cardiac failure, finally increasing the mortality and morbidity. So the treatment of depression, an early diagnosis of depression could help in improving the quality of life of dialysis children. And one is non-pharmacological by CBT, cognitive behavioral therapy. It's a psychotherapy which helps patients to dissect relationship between emotions, cognition, and controlling their negative thoughts. And exercise also helps. Pharmacological, if they have a major depression, then selective serotonin uptake inhibitors can be used. So initially we have to assess not only the physical but also the psychosocial status. You have to take a history in detail with the biodemographic data of the child, the age, sex, birth order, level of education, resilience, and living conditions, pre and post hemodialysis complaints, nutritional habits, especially for anorexia, sleeping pattern, that is number of hours of sleep or any sleeping problems, you have to inquire. Exercise, easy fatigue due to anemia. So the fatigue is mainly due to anemia, so they hardly do any physical exercise. School attendance and achievement irregular, and frequent absenteeism and overprotection by parents. Next common disorder is the anxiety, according to DSM-5. It is overwhelming feeling of the fearfulness, dread, and uncertainty. Nearly 38% have been reported to have this, but no RCTs are available, and has a negative impact of quality of life and general health. Anxiety is more in dialysis children than in transplants. Since not much of RCTs are available, we have not worked out much in this. Okay, our main problem is the non-adherence to medications, to self-care. So this leads to life-threatening complications like poor compliance is a modifiable risk factor. These the chronic anemia, pulmonary edema, uncontrolled hypertension, cardiac failure, failure to respond to medications, emergency visit to hospitalization, and hemodialysis, 60% have fluid overload, whereas in CAPD, peritonitis is more common. Frustration and dissatisfaction to all. So there are multiple factors in non-adherence. One is patient-related, as I told you, age, sex, the health belief, and I cannot see the slides. Interpersonal communication, socioeconomic status, that is the income and social support. And disease per se because of the uremia, and perceptions. Perception, that is, one is the illness perception, that is how they appraise their own health, and if they have a good perception of their own illness, then their quality of life is better. And therapy, this is about the medications, compliance with the medications. Dialysis environment, patient to physician, diet. This is a dialect between the patient and physician. The physicians must communicate to the patients one is to one, and clear their doubts. And the next is mainly the depression, the hopelessness, negative self-image and outlook. So finally, this is the self-efficacy belief or the health literacy, that is the knowledge about their disease so that they can discuss with the physician and make their own decisions. So decreased self-efficacy leads to increase in potassium and interdialytic weight gain. And so enhancement training increases the quality of life. And the main problem, especially for us in India, is the financial burden. One is treatment related, that is dialysis. The patients have to get the dialysis accessories very frequently, and also medications are expensive. Health related, the transport, they have to come to the dialysis centers, lodging. If they are coming from a far off place, they have to take a lodge and stay. And foods for the family members, those who are accompanying the patients, and traveling long distances to reach the dialysis centers. All this attributes to a lower quality of life and higher incidence of comorbidities. And the lower income group suffers more, and they show poor adherence, pointing to the economic strain placed on the caregivers of CKD children on dialysis. So in order to, for the patients to comply with the CAPD, home visits by the personnels attending to these patients is very much useful, because it reduces the technique failure in CAPD children, improves the standard of care, optimization of the environment where PD is done, increase adherence to prescriptions, reduce the risk of infection, and reinforces patients' confidence in self-care, reduces peritonitis rate and PD-related complications, hospitalizations. Next is the health-related quality of life. Quality of life is defined as a sense of well-being. It is accepted as a salient health outcome and measure of treatment efficacy. And it is attributed, it is multifactorial. One is due to renal because of anemia, comorbids, and medications. And dialysis itself leads to the depression, cognitive impairment, symptom burden, care burden, nutrition restriction. And these patients have low physical activity. They say 75% of the children do not have any physical activity. This increases the risk of death, and by increasing the activity, physical activity, these children will have better sleep and lesser pain. So children undergoing dialysis have learning difficulties also, and also poor participation in school activities. Irregular school absenteeism, frequent frequent absenteeism, and 20%. I cannot see the slides. Can I put my slides? Kalayani. Learning difficulties. Nam slide போட முடியாதா?
Slide is very much visible.
For me, it is not seen. It is about transition.
It is very much visible, ma'am. Whatever you are seeing, only like we are also seeing. It is, a view is going to be the same. You're able to see now, ma'am?
Yeah. So learning difficulties, they have irregular school attendance, frequent absenteeism, tendency to tire easily. 20% of them failed to pass exams. 36% secured very low marks. And this was attributed to thrice weekly visits to hospitals for dialysis, leading to irregular school attendance and impaired concentration, low achievement, and finally poor participation in school activities. And they have studied even the spirituality. Brown studied the spiritual behavior of children under regular hemodialysis and found out that 50% of the children did not pray regularly because of fatigue, tiredness, and frequent hospitalization. So they concluded that greater level of religiosity and spirituality improved the cognition and fewer abnormal emotional behavior attitudes. Coming to the social relationship with peers, 86% found that they received kindness, and only a small number faced violence and teasing. 80% complained of overprotection by parents and 10% of sibling favoritism. 70% experienced good relationships, and 60% faced teasing and 10% incongruence with each other. 10% were not visiting their relatives. So make it a point to really visit your relatives also. Okay, coming to sleep. Sleep disorders are common in ESRD children on hemodialysis. It is multifactorial. 70% of them slept less than 8 hours per night. 53% had interrupted sleep. 1/3 had sleeping difficulty like sleep apnea. 69% had insomnia, daytime somnolence. Sleep initiation, maintenance, and adequacy are associated with low vitality. Hypersomnia was due to depression. Daytime somnolence was due to uremia and medications and other metabolic changes. I had a boy who was on CAPD, and mother used to get up at 3 a.m. in the morning to do the exchanges. And she used to see her son staring wide at the roof, and she was shocked. So insomnia is very common in children. So management is sleep hygiene education, that is regular sleep schedule, going to bed at the proper time and getting up in the morning at the same time. Increased physical activity improves circulation, leading to induction of sleep. Again, CBT improved sleep. sleep latency, daytime dysfunction, and fatigue. Medications, benzodiazepam helps, but increases mortality, especially in patients who had COPD. Now, moving on to the role of social care workers, treatment non-adherence in ESRD has been widely researched and remains a challenge for the care of these patients. Globally, the KHA CARI guidelines on CIKD management suggest involvement of social workers in the early stages. Social care workers must be involved in patient care, communication, and interpersonal skills to handle sensitive patients. Patients' rights must be known to them within 3 treatments after admission. Non-compliant issues like failure to treat patients with respect and dignity, to provide an opportunity for private communication, and also prevent exposure of private body areas. 2, patients and caretakers not being aware of other options for treatment modalities or grievance mechanisms, rude or demeaning behavior, physical or mental harassment are not acceptable and must be imposed for purpose of discipline or staff convenience. So the most common social work consults related to patients with difficulties are with adjustments, treatment to non-adherence, management of finances, and domestic assistance. We found that age, timing of referral, financial status, and parents' employment status were independent predictors of adjustment issues. Age, financial status, and employment status were also independent predictors of treatment non-adherence. Adjustment issues problems were the commonest problems identified in 41% of patients. Patients referred prior to starting RRT were more likely to have adjustment problems rather than those referred after commencement of RRT, 72 versus 21%. So these children require a rings of support, starting from the pediatric renal team, where the dialysis technicians and nurses supervise them. And while they're having the dialysis, the school teachers teach them. If the children are young, play therapist can help them. And home nurses, babysitters, and psychologists also play an important part. And most important is a social worker and dietitian who gives the fluid and diet restrictions. So this promotes a holistic approach to the child care. So next, moving on to the burnout. The caregivers, ESRD children on dialysis rely on non-professional healthcare providers like family and friends to manage their long-term conditions through the trajectory of CKD. These informal caregivers can have stress, depression, lack of confidence, and poor quality of life. Needs of caregivers are often neglected and under-prioritized. So burnout, what is burnout? Burnout is defined as to suffer physical or emotional exhaustion. So they need a social work support to help them the loss of income, transport costs, sibling issues, family relationships, referral to psychologists in clinic or joint home visit. Respite care. Respite care is temporary care for these caregivers for prevention of burnout, like giving a night of dialysis if possible, babysitting with the help of charity funded, and respite care nurses who come for the day, and this is managed with the charity funds. and holiday support is organized by the unit. In Mehta Hospital, every year we used to take these children by bus to some resorts and spend the whole day with them. So that is an example. And charity funded transport and travel. Youth support, involving youngsters to support is very essential because they move about with the children and they also have their own work projects. Okay, so ultimately transplant is the destination. Transport and relocation difficulties over extended periods of time have been cited by parents of pediatric renal transplant recipients. The unavailability of kidneys for transplant, poor growth, dependency, and loss of hope were factored as the main problems faced by patients. 77% of the families preferred preemptive renal transplantation, 17% peritoneal dialysis, while only 2% preferred hemodialysis. According to the American Psychological Association, 50% of the patients will experience at least one episode of anxiety or depression within the first 2 years of the post-transplant period. 25% will display post-traumatic stress disorder symptoms. Renal transplantation is a serious and life-altering surgery. It is critical that the patient and their family understands the surgical risks involved and the long-term compliance is necessary to improve the patient outcome. Actually, I had a girl who father gave the kidney, and but she was very non-compliant, and she never took the medications, and so finally she went into rejection and expired. So psychological evaluation is a must pre-transplant. This is for patients' understanding of procedure itself, patients' acceptance of the requirements for maintaining a positive surgical outcome like compliance with immunosuppressives, lab tests, and routine clinical visits. All the pre-surgical psychological evaluations are routinely conducted. Appropriate psychological test to use is underdeveloped. Despite the scarcity of research, instruments that appear to be useful in this population include Minnesota Multiphasic Personality Inventory, Personality Assessment Inventory, Stanford Integral Psychological Assessment for Transplant, Transplant Evaluation and Rating Scales. So next time when you do a transplant evaluation, please check whether one of these are there, because usually they give a consent, but after the transplant, we see that the patients are non-compliant and they don't know the seriousness of the transplant. So to conclude, although the extent of one's physical illness affects their psychological functioning, the strength of their ability to cope up can impact the course of their medical illness. As the future of pediatric renal transplant appears brighter, a multi-pronged approach to tackle these lacunae is essential to give these children a rebirth with a new kidney. Thank you.
Thank you for the very elaborate talk. We all know that the psychosocial support for these children in CKD is very, very essential. And in fact, we spend more time talking to the patient rather than treating them, making a diagnosis or looking into their files isn't a big issue, but talking to, even when we talk to adult patients, we take a lot of time to talk, and talking to children and their parents, and you know, they you have to talk. The pediatric patients also will have some uncles and aunts and grandmothers and grandparents coming in, and a lot of talking has to be done. Thank you for an extensive talk, ma'am. As usual, we'll take questions at the end. Correct?
We'll take the questions at the end, sir.
Okay, fine. So it's my pleasure today to introduce one of our fellows from Mehta Hospital, Dr. Amish Udani, who's making big waves in the field of pediatric nephrology at Mumbai. And Amish will be talking about the immunology of transplantation in relation to pediatric transplantation. Amish, are you ready with your slides?
Yes. Can you hear me?
Yeah, yes, you're audible. Yes, you're audible.
Yes, sir. Good evening, everybody. Today we will be talking about immunology of pediatric renal transplantation. I will be covering this topic on these points. First will be the graft terminology, then the immune system, how it behaves in helping to reject a foreign particle or an antigen, mainly the infections, the malignant cells, and in case of transplant, how does it help to develop tolerance so that it does not reject the self-donor antigens. The pathways of allorecognition, then the types of rejection, then we will be talking about the how transplant so that in long run we have a better graft function without need for immunosuppression. Then last but not the least will be the ischemia reperfusion injury, which itself can cause rejection, and the effector mechanisms, which ultimately lead to transplant rejection. So coming to graft terminology, we have various types of graft available. The first is autograft, wherein one part of the body is grafted to another part of the body. For example, skin, the vessels. As the same individual, there is no rejection with. Second is an isograft, wherein you have a genetically identical twin, which will share the same HLA, and if an organ is transferred or donated from one twin to another twin, it will be called as an isograft. We don't see any rejection. Third is the allograft, which is commonly done because of the non-availability of a genetically identical twin. You can have a live related donor or cadaveric organ. Since from a different individual but of the same species, it will be called as an allograft. And last is the xenograft, wherein you are going to take an organ, different species altogether. There are chances of rejection which will be seen if you are going to use an allograft or a xenograft. Next, we will learn about the immune system response. We have two arms of the immune system. First is the innate immunity, which is non-specific. It has rapid onset of, it has less memory, so that if there is a exposure to the same antigen, immunity, because of having less memory, cannot act immediately. Really, it is alone the cause of or it can induce rejection. The components of the innate immunity are divided into two. One is the cellular components, which include the neutrophils, macrophages, the natural killer cells, cytokines, the complement system. And the second component is the molecular component, which is the pathogen-associated pattern recognition receptors, which basically release the cytokines, tumor necrosis factor, interleukins, and chemokines. The second arm of our immune response is the adaptive immunity. Antigen specific, and it has memory by the T cells as well as the B cells. The adaptive immunity itself will stimulate the components of the innate system, and like the cellular components of the innate system, like neutrophils or other macrophages, as we have discussed earlier, or it can also lead into chemokine and cytokine secretions. Basically, in the adaptive immunity, you have a specific, and either it can be a virus or a bacteria or a malignant cell. It is taken up by the antigen presenting cell of the, and this host or a recipient antigen presenting cells are basically the dendritic cells, macrophages, or the, this antigen presenting cell will present this an antigen to the secondary lymphoid organs in the lymph nodes and spleen, and will activate the MHC or the HLA, mainly the CD4 cells. Here, in transplant, if the donor antigen presenting cell presents the donor major histocompatibility complex as a peptide to the recipient T cell, it will result in direct pathway of allo recognition. Other mechanism is the recipient antigen presenting cell will identify the foreign or the donor histocompatibility complex protein along with the recipient major histocompatibility complex to the recipient T cell, and it will cause activation of a immune response. We will be discussing these pathways in detail later on. So coming to histocompatibility complex, the HLA, as we have two classes mainly, the class 1 and the class 2. The class 1 is including the HLA A, B, and C. And in transplant, we give importance to the A and only. Few centers also give importance to the C. It is the class 1 HLA complex is present on all the related cells. This have cytosolic proteins, and it will detect tumors and the intracellular pathogen like virus or the bacteria. The class 1 will stimulate the CD8 cells and will cause destruction of that infected cell of cytotoxic lymphocytes. Here we can see the structure of the HLA class 1, which is quaternary structure, and it has alpha and alpha 2, alpha beta 2 microglobulin. The second is the class 2 or MHC. Class 2 is the HLA, DP, DQ, and DR. This transplant, we give importance to the DR component. This is present in bone marrow derived professional antigen presenting cells like the dendritic cells, B cells, macrophages, Langerhans cells, or activated parenchymal and endothelial cells. These are basically extracellular to the class 1, which is in the cytosolic component of the cells. And this class will present the foreign antigen or the virus or the bacteria to the CD4 cells. There is always cross presentation, where in this process extracellular antigen which can be presented instead of class 2 to class 1 molecule and activate the CD8 T cell. This mechanism is necessary for immunity against tumors and viruses that do not infect the antigen presenting. Coming to basically we do the HLA typing of the recipient by DNA method, and you look for the alleles. So as we said, though the HLA has a quaternary structure, but it can undergo polymorphism, wherein they have a wide range of access to different viruses or bacteria or foreign antigen. And when we are doing the DNA typing, we take two alleles of each class 1A and B and of class 2 DR. So if we will have 6 alleles which will be identified for the recipient. And if you see the siblings from the same set of parents, you will have 25% chance of having zero mismatch. So even though it is not an identical twin, but a second sibling may have inherited the same alleles from the both parents. You may have 50% chance of one haplotype mismatch, that is 3/6 match, and have 25% chance of two mismatch. So even though it is a sibling, but it may not have a match as so for example, here there is a father and a mother, and we have class 1A, B and class 2 DR, and these are the two alleles which are identified. It is A and B. Similarly for the mother, we will put it as C and D. So if you see sibling 1 from parent A and C, so A and C is inherited for sibling 1. 5% chance that the sibling will have the same inheritance from both the parents. Or you may have 50% mismatch, that is sibling 2 and sibling 3 has one haplotype match. For sibling 2, it is the A, which is similar, and sibling 3, you can see between sibling 1 and sibling 3, you have C match for A, B, and DR. So it is one haplotype match, one haplotype mismatch. If you see the sibling 4 inheritance, none of them is matching with sibling 1. So you have haplotype mismatch. So even though they are siblings from the same set of parents, but sibling cannot be a donor to a sibling 1. Coming to typing, earlier we had serologic methods to do HLA typing. It incorporated what we use for blood group typing. In this, viable lymphocytes, and it is mixed with which will contain the HLA antibodies. It has limited screening, and it may have variability among the labs because the samples of HLA which one lab may have same HLA specimen the other lab may not have, and you need viable lymphocytes are very necessary for this methodology. But nowadays we have DNA based HLA typing method, which is a PCR based and has specificity of the primers. So you have a population and you choose for the look out for the HLA in that population or in that area, and based on that you develop PCR primers. It can be sequence specific primers, that is SSP, or it can be sequence specific oligonucleotide probes, that is SSOP, and you want to find new alleles which is not present in the individuals of that area, but still you can have newer alleles which can be present, and it can be done sequence based typing method, that is SBT, but it is time consuming. So basically now we use SSP or SSOP method of HLA typing. So coming to next slide. Now, since we know that most of the complications in a transplant, other than infections because of immunosuppressive therapy or malignancy or the recurrence of disease, is the rejection. we try to minimize the rejection by doing cross match. By doing a cross match, we can find out whether the of the donor or the recipient has any preformed antibodies present. So the first we do the available in the earlier days was the cross match, that is complement toxic cross match. Here the donor lymphocytes are mixed with the recipient serum and rabbit serum is added as a complement. The T cell lymphocytes will represent the HLA class 1 and B cell lymphocytes will have both the HLA and 2 both. The limitation of this study was it does not check antibodies on the endothelial cells. These endothelial cells are present in RBCs or in bone marrow transplant where there is transfusion. Renal transplant, since we are going to have an organ which are not having much of endothelial cells, we check only for the lymphocytes. But the caveat to the test is again we need viable lymphocytes for a proper. Now the possibilities are you have a T cell positive cross match but a B cell negative cross match. It can happen because of the presence of non-HLA antibodies, or you may have to repeat a test due to technical error because of presence of B lymphocytes. The second option is you may have a T cell negative cross match or a B cell positive cross match. That means there is presence of HLA class 2 antibodies or low titers of class 1 antibodies. Now whether these antibodies belong to IgG or IgM is important, and this can be checked by adding the substance called dithiothiol or 2-mercaptoethanol, or you can heat it at 63 degrees centigrade for 10 minutes. If you have a positive B cell CDC cross match but negative B cell CDC after adding BTT, that means it is presence of IgM antibodies or inactive low levels of IgG antibodies. In that case, again, of having rejection will. Nowadays we have a better method wherein instead of using the rabbit serum, you have a fluorescence labeled anti-human globulin which is checked in the CDC flow cross match. It is more sensitive as it does not depend on the complement for a report. Have limitation detecting clinically irrelevant antibodies. So in case if you have a negative T cell CDC cross match but a positive T cell flow cross match, that means it is a non-complement fixing antibodies like IgG2. So in this case, if there is no presence of prior sensitization like history of previous blood transfusion or pregnancy or prior transplant, then this positive T cell flow cross match does not have an increased risk of acute rejection. In case of cadaveric transplant, we do a array test whether when the patient is up on the list or is going to be receiving a transplant in next is on the cadaveric list. If it is on the top number, then do the PRA test. Here you check the donor of the area along with the recipient serum. So in this we utilize the donor lymphocytes of that particular area along with lymphocytes, and from suppose 100 blood donors, and it will represent the local population of the potential donors. If you have any sensitization, then post-transplant recipients may IgG which can cause rejection. So if you have a report where it is reported as positive in 80 out of 100, that means the recipient will have acute rejection in 80% of. a normal, if you have a less than 5% PRA positivity, that means the recipient is not sensitized. And if it is more than 20%, then either the recipient will need to have undergo desensitization protocol drugs, receives a transplant. Next is the donor-specific antibodies. Utilizing donor T lymphocyte or B lymphocyte. Here, due to the sensitization from prior transplant or pregnancy or transfusion, the potential transplant recipients may have preformed IgG, which will be specific only to the donor against HLA. Here you can do by two methods. One is ELISA method, the Luminex method. ELISA method, we specific purified HLA molecules on the plastic surface and add globulin. It will detect IgG antibodies, but limitation of this is the HLA which is detected by DSA method is in secondary structure and not the quaternary structure, and it does not distinguish between complement and non-complement activating antibodies. The quaternary HLA structure will be detected in cross seen previously. In Luminex method, we have specific synthetic HLA molecules on the fluorescent microsphere wells along with anti-human globulin. It can be used as a screening test for presence and specificity of the anti-HLA antibodies. So if you have DSA positive or you have C4D, the complement activation seen on the renal biopsy and immunofluorescence, or the histopathology might be suggests antibody-mediated rejection, then all things will be taken antibody-mediated rejection and treatment will be according to that. But if you have T-cell mediated rejection, then the treatment will differ. We will come to that on the later slides. Now we will talk about pathways of allorecognition. So once we have identified the we have identified the recipient, instead of that we have gone through the transplant, still there is chance of developing rejection because of allorecognition. As we discussed earlier, direct or indirect method or the semi-direct. In direct pathway, the recipient T cell recognizes donor MHC peptides in the peptide group of intact donor MHC molecules present on the surface of donor antigen presenting cells. So basically what I am trying to tell is the donor antigen presenting cells are shed from the graft, and along with the donor MHC, it will present the peptide to the recipient T cell in the secondary lymphoid organs, mainly the lymph nodes and the spleen. The donor antigen presenting cells will migrate from the graft to the recipient lymphoid organs and activate alloreactive recipient T cells to initiate the alloimmune response. In the semi-direct pathway, this intact donor MHC peptide complexes which are shed from the graft are contained in the cellular vesicles, and these are derived from the donor antigen presenting or from the graft, and it will be presented to the recipient antigen presenting cells, which will further take up to the recipient T cells in again the lymph nodes or the spleen. This process is called as cross-dressing or cell nibbling. B cells may also recognize intact donor MHC antigen via their B cell receptors. The commoner pathway, which is the indirect pathway for allorecognition, is the recipient antigen presenting cells process the donor MHC molecules and minor histocompatibility antigens which are shed from the graft and they present it as peptides to the recipient T cells in the context recipient MHC molecule. So the recipient MHC molecule will identify the donor MHC molecule as foreign, and it will be taken up by the recipient antigen presenting cells. As we said, the antigen presenting cells are the dendritic cells, the macrophages, Langerhans cells, etc. So to summarize, the two pathways which are common is direct and indirect pathway. So on the top here, the donor antigen cell presenting the donor MH along with presenting the donor peptide to the recipient T cell directly. And in the indirect pathway, instead of the donor antigen presenting cell, the recipient antigen presenting cell with the recipient MHC identifies the donor MHC peptide, the red dot, to the recipient T cell and activates the alloimmune response. Coming to the types of rejection, we know there are mainly three types of rejection. First is the hyperacute, second is acute, third is chronic rejection. The hyperacute rejection occurs because of the rapid thrombotic occlusion of the graft vessels, which begins within minutes after anastomosis of the vessels. It is due to the pre-existing antibodies which bind to the vascular endothelial cells and activate complement. For example, if you have ABO incompatibility or prior sensitization to HLA or polymorphic antigens present on the endothelium. But we rarely see now because of the availability of the cross match, which we do pre-transplant. Coming to rejection, here you have necrosis of parenchymal cells. It is basically mediated by two types. Either it can be T cell mediated rejection or an antibody mediated rejection. They may share pathological features. It can occur early or late, or it can be fulminant, or it can be slowly progressing. The T cell mediated rejection is classically described on histopathology as tubulitis because of infiltration of monocytes, macrophages. This will cause damage to the tubular epithelium by cytotoxic lymphocytes, anti-CD103, and release of cytokines. A set of biopsy may show end arthritis without presence of any tubulointerstitial damage. And in this, if you give anti-T cells, we have seen response. The anti-T cell therapy is mainly high dose of steroids or ATG or high dose of calcineurin inhibitors with tacrolimus trough levels more than 20. And they respond to this medication. And so end arthritis may also cause of T cell mediated rejection. A few biopsies, you may see glomerulitis, which is again of T cell or macrophages mediated through FOXP3 with T regulatory cells. The description of antibody mediated rejection on histology is the donor HLA antigens which are expressed on the endothelial cells. Mainly you have injury, C4D, infiltration of leukocytes with FC receptors, mainly F16. It includes natural killer cells and macrophages, leading to antibody-dependent cell cytotoxicity. This is the immunofluorescence of C4D staining, and here you can see platelet addition and aggregation, which will cause on the thrombosis on the glomerulus. This. So even if you don't have a biopsy picture which is suggestive of antibody-mediated rejection in terms of C4D being negative, or you have histology which is not specific for acute tissue injury, but you have donor-specific antibody which are positive, then you may conclude that it is an antibody-mediated rejection. Here, donor HLA antigens, without having non-HLA antigens also, you may have antibody-mediated rejection, especially if you have ABO incompatibility or LO or because of antibodies to angiotensin 2 type 1 receptors. The treatment for antibody-mediated rejection is plasmapheresis, IVIG, anti-CD20 antibodies, that is rituximab, or available proteasome inhibitors. So to summarize the acute rejection, as we said, T cell mediated rejection. Here you have T lymphocyte, the CD4 lymphocyte, which can activate the cytotoxic T lymphocytes, and it can release enzymes like perforin granulozyme B and cause damage to tubular epithelial cells mainly. As we said, the T cell mediated rejection have classically tubulitis on the histopathology. It can cause damage to the tubular cell by apoptosis. This CD8 cells can, along with MHC1 alloantigen, which will attach to the tubular with the help of T cell receptor CD3 complex, or it can bind to the tubular epithelium of fast ligand with fast receptor, and again it will cause damage to the tubular epithelial cell, tubular cell. The CD4 lymphocyte can activate macrophages, cytokines, and cause of the tubular. The CD4 lymphocyte can activate T cell or will cause release of or pre-existing antibodies, can activate the B cell, endothelial cell.
Sorry to interrupt. Dr. Amish, sorry to interrupt. Can you please switch off your video? Your voice is getting breaked. Your audio is not all that clear. Can you please switch off your video so that your audio becomes better?
No problem.
Yeah, fine. Thank you so much.
Okay, now. So I was talking about antibody-mediated rejection, where you have activation of the B cell because of the antibodies, preformed antibodies, which will cause damage by fixing the complement and cause exposure of the subendothelial cells, cause release of von Willebrand factor, platelet addition and aggregation, and activation of the coagulation cascade, and resulting in thrombosis, which is the primary feature seen with antibody-mediated rejection. And in chronic rejection, mainly we see the transplant glomerulopathy, which is identified as duplication of the glomerular basement membrane, mesangial expansion, and mononuclear infiltrate. You may have peritubular arteritis manifested as duplication of basement membrane with or without positive C4D. Transplant arteriopathy, which can be seen as a thickening of the arterial intima, infiltration of macrophages and T cells with atrophy and interstitial fibrosis. It can be alloimmune dependent, as we said, it can be mediated by T cell or B cell mediated process, or it can be alloimmune independent because of hypertension, long-standing, or calcineurin inhibitor toxicity, or recurrence of the disease. So the ultimate aim is to develop transplant tolerance, which is by two mechanisms, the central mechanism and the peripheral mechanism. The central mechanism happens in the thymus. So in adults, if the thymus is involutes, central mechanisms will not play a role in developing transplant tolerance. Here, the thymus will eliminate the T cells with reactivity against the self or the donor antigen. So basically, if you have a bank staff who is highly suspicious of all your customers, and it will not allow cashing of the check, then the bank manager will remove staff, and it is a process called as selective selection. And the bank manager may select a bank staff who is less suspicious of all the customers, and will have this process is called as positive selection of the T cells, which will not have any reactivity. And the peripheral mechanisms are deletion of the T lymphocytes which are activated, energy or develop tolerance to those lymphocytes, and regulate by inhibitory pathways which are activated. This is achieved with co-stimulatory blockage, pharmacological manipulation, which are the antigen presenting cells, and induce donor antigen specific T regulatory cells. The non-major histocompatibility complex antigens. These are polymorphic proteins which are present in the same species. For example, if you have a genetically identical twin, the recipient is a female and the donor is a male, then the recipient, which is a female, develop antibody to the Y antigen which is in the donor male. So it will also cause initiation of the alloimmune response and may cause rejection. There are other antigens which is called as MHC1 related A and ABO blood group glycolipids, which we already know, which can cause activation of the alloimmune response. Lastly, we are coming to ischemia reperfusion injury. It is because of the insult which happens to the graft during donor organ procurement. It can activate biochemical, cellular, vascular, endothelial, and tissue-specific factors which will cause inflammation. Ischemia, which is induced during tissue damage and endothelial activation, will happen through innate immune system. This will result in delayed graft function. Ultimately, if once you have T cell is activated, the effector mechanisms for this are the T cell receptors, CD4 and CD8 co-receptors, CD complex, T cell co-stimulation, T cell clonal expansion and differentiation, CD25 IL2 receptor, development of memory cells. It will cause cytotoxic release of cytotoxic lymphocytes with enzymes like perforin, granulozyme, etc. bind to the tubular epithelium with and mainly CD95. It can activate macrophages or B cell activation through B cell receptor and natural killer lymphocytes. All these are going to damage your either the tubular epithelium or the endothelium and lead to rejection. So to summarize, if time of transplant, ischemia reperfusion injury, the graft damage can cause innate immune response, recruitment of inflammatory cells, and initiation of adaptive response of the immune system. The second is if there is no ischemia reperfusion injury, the second mechanism to develop is the antigen presentation. If you have migration of the dendritic cells to the secondary lymphoid organs by direct or indirect allorecognition pathways, it will cause MHC T cell interaction and lead to rejection. The T cell activation, once it has happened, it will cause T cell as signaling, co-stimulation, cytokine production, and clonal expansion. The fourth mechanism would be the effector functions of the CD8 cytotoxic T lymphocyte. It will lead type of hypersensitivity reaction, antibody reaction through B cells, and cytotoxicity by either release of enzymes like perf or granulozyme B, or release of cytokines, or TNF alpha. Ultimately, it will lead to graft rejection by leukocyte infiltration. It can be either by T cell mediated or antibody mediated rejection, and it will lead to graft damage ultimately. Thank you.
Thank you, Amish, for a very exhaustive presentation on immunology. You know, it's very difficult to cover this topic in a nutshell like this. It requires a lot of understanding of basic immunology that we read as undergraduates, and then to apply this immunology to the renal transplantation situation. A lot has been made in this, done in this field, in the sense that HLA matching, which was in our country, it's become a law in the sense we have to prove the relationship by a HLA for related donors. The methodology by which this is done is also undergone a lot of transformations. Initially, it was a serology-based test, and now it's a molecular testing by PCR technique, where you can actually go up to the epitope, and people also look at even the eplet matching to make matching a little more precise.
Yes, sir.
We do have a problem of having a nil match among siblings, in which case you'll have to probably call the parents for HLA matching too, because the children would always have a 50% haplomatch with the parents.
Yes, sir.
So, and you definitely need to do the DR typing, and the DR typing can be done only by molecular methods. Regarding the cross-match, conventional cross-match is the CDC cross-match that most centers do. But now people are looking at the Luminex cross-match. Whether the Luminex cross-match has actually added more information or made things clear, no, not. It has added actually more to the confusion. The combination of the Luminex cross-match and the DSA by a single bead antigen or by the Luminex technology again adds to the cost for the patient, nearly costing about 40,000 rupees, which is huge amount of money. So CDC cross-match done properly, and augmented CDC cross-match like addition of anti-human globulin or addition of dithiothritol, though they are old techniques, they have been time tested, and a center like ours, which has done nearly about 800 transplants, we have never gone for a Luminex cross-match at all. We still continue to do the CDC cross-match. We haven't had any major problems. But
yes,
when these techniques are available, professional bodies too tend to include this in their protocols, in their guidelines which they make, which makes practicing very difficult, because when we get into a legal tangle, these issues do come up. And unless we have our own guidelines on the DSAs and the MFIs, etc., it's going to be very difficult, because if you're going to apply the Western standards to our population and define cutoffs based on this, we'll land up with more confusion. As of now, the DSAs and the Luminex cross-match definitely are not very clear. They add more to the confusions. We depend more on the good histopathology to diagnose rejections. Of course, the DSA monitoring would definitely be helpful if done the right way, and if it is you do on a large scale and the cost comes down, it will definitely be useful. So is there any questions? I don't find any questions here at the bottom.
There is one
this
question
HLA is
left.
This HLA is a very dry topic. Yeah. What is that about?
Why does Burkitt's have spontaneous tumor lysis syndrome? The question is directed to Dr. Aruna.
Hey, Dr. Aruna is there?
Dr. Aruna is there, sir.
Yeah. So, Dr. Aruna, can you take that question?
So actually, Burkitt's is one malignancy where the proliferation index, it's called K67, is almost 100%. That is, every cell, when it is looked into by histopathology, will be in mitosis. So every cell will be a dividing cell, and it is has a very short generation time. That is within the generation time is around 24 hours. So almost the tumor will be doubling every day in size. It is one of the very high grade non-Hodgkin's lymphoma. Because of the extensive cell turnover, there will be equal number of cell dying and equal number of cell being formed every day. So this leads to a high cell turnover and spontaneous tumor lysis in Burkitt's. A similar scenario exists for other non-Hodgkin's lymphoma and leukemia, but it is maybe the extreme level of cell turnover happens in Burkitt's.
Probably this happens with any large nodal masses or large lymphomatous tissue, where a protein breakdown could be quite large, and spontaneous TLS has been described in this group of patients.
Edwin, sir, there are two more questions. You are able to view the questions, sir?
No. Can you read them out for me?
Yeah. Does CDC has more issues of subjectivity as compared to flow? Also, how do we interpret results after Luminex positivity in an otherwise high-risk patients? Does it add to management then?
Amish, you want to take that question?
I didn't get the question. Can you repeat?
Does CDC has more issues of subjectivity as compared to flow cytometry? Also, how do we interpret results after Luminex positivity in a otherwise high-risk patient? Does it add to the management then?
Yeah, so if it is not a high-risk patient, then the standard CDC cross-match is sufficient. As Dr. Edwin Fernando has already pointed out, by Luminex method, we may detect irrelevant antibodies, which will be seen as a positive result. It may not have relevance in terms of development of rejection. But if you have a patient, especially if you have a patient who has received prior or pregnancy or has exposure to a previous transplant, and this is now a second transplant, in that case you have to be more careful. And if you have a DSA positive, then Luminex based, then you may use pre-transplant desensitization and bring down the DSA levels to negligible before you go for transplant, actual transplant. Sir, am I correct in interpreting the question and answer?
Yeah, you're more or less right. You have to be very careful when you are doing a second transplant or a high-risk transplant. Otherwise, standard CDC cross-match is well and good. As I mentioned earlier, in our experience of nearly 1,000 odd transplants, with the CDC cross-match, we haven't had any major problems. Most of the antibody-mediated rejections came when patients were non-compliant to therapy rather than a big immunological process. In fact, I mean, as a policy, we don't transfuse nowadays because of availability of erythropoietin widely available and also economically viable now. So erythropoietin is freely available. So we avoid transfusions. That's fine. Again, any immunological test, or for that matter, any test is observer dependent, and we find that technicians and people working on these tests do get better with time and with better experience. It is our duty to give a feedback to these people when we find something gone amiss. If you find a CDC cross-match that's reported as 5% positive or 10% positive, and you get an antibody-mediated rejection on that 48 hours, then I think we must go ahead and then inform this group. We can even do a cross-match after the transplant and check. So these are ways of improving the laboratory services. Any laboratory is going to get good only with a lot of experience. And as my teacher, Dr. Mutsidwadi, used to tell, that the lab is as good as the clinician who's using it. So we must give positive feedback to the laboratory, for positive or negative, whatever. That feedback to the laboratory is very, very important. If you look at the cost involved in doing HLA matching by molecular method and looking at a DSA and or looking at a Luminex cross match, this itself will cost 1 lakh to the patient in a commercial lab outside. So that's huge cost. When you're trying to cut down the cost of transplant to 5 lakhs or 5.5 lakhs, the Tamil Nadu government gives 5 lakhs for all the transplant recipients to get transplanted in a private hospital. Now you're going to spend 1 lakh for immunological testing alone, then it's very difficult to run the program. So it's better that we don't rock the boat much. Go with the time-tested techniques. Of course, we are in for change, and we have to slowly learn how to use them, and then a little more widespread use would probably bring down the costs of these tests also. Is there any other question?
There is one question, I think it can be confidently directed to Edwin, sir, because is the brother's wife considered as a relative for sister's husband? I think you will be the right person to answer this, sir.
No, the Human Organs Transplant Act defines a near relative as parents, siblings, or children. The spouse is taken as defined as a near relative as per the law. It is the spouse is not a biologically related person, but an emotionally related person. Some expansion and amendments have come where grandparents have been taken as prospective donors, especially for pediatric group, where the child may be 5 years old and the grandmother may be just 55 or 56. So that expansion has happened. No other relationship is considered as near relative. The definition of near relative is ones that I have mentioned. Of course, a brother-in-law or a sister-in-law or a mother-in-law or a father-in-law can donate. They are not considered as near relative. They have to go through an official committee from the government, take permission, and it can be done. But they are not considered in the group of near relative, because once you define near relative, you need not actually send to the committee. You can prove the relationship by HLA typing. And if it is a spouse, you can actually get the marriage certificate, photographs, and still proceed to the transplant. But if it is other than near relative, like a mother-in-law, father-in-law, it has to go through proper government approvals before a transplant is made.
Okay. So there is more a comment on the question. At times, we send a sample for DSA and is reported as 0% PRA. They say it is done as single antigen B. I tend to confuse with the report as what does it exactly mean? Does it really answer the query?
I really can't get the question. What is it?
Like many a times when the sample is sent for DSA, the report is read as 0% PRA, and they say it as single antigen bead. It is done through single antigen bead. I then tend to confuse with the report as what it exactly means. Does it really answer the query well that there is no DSA?
Yes, if they say there is no Yeah, if they say it is 0, then there is no detectable donor-specific antibodies. That's it. However, there could be some minor antigens which cannot be actually picked up by even the single antigen bead. There could be some or very low concentrates of some antibodies cannot be picked up. Non-HLA antibodies cannot be picked up. So we have to go by the DSA. Of course, the SAB is one of the most sensitive methods of doing a DSA.
I think we are done with the questions, sir. You have anything to add on, sir, Edwin, sir?
All the 3 talks were very good and very relevant topics. Prabha Madam's talk on psychological evaluation of children on dialysis, and Dr. Aruna's talk on onco-nephrology and the multifaceted role the nephrologist has to play in the field of oncology, and Dr. Amish's talk on the immunology of renal transplant were all very interesting and all well done. And I must thank all the speakers, and I must thank Dr. Kalivani for organizing this IPNA web meetings. So if there are no other questions and queries, we could wind up and say good night.
Yes,
Thank
sir.
you all. Thank you.
Thank you so much, sir. Thank you, Aruna ma'am. Thank you, Dr. Amish. Thank you, Prabha ma'am.
Yeah,
Bye-bye.
thank you.
Thank you.
Good night. Good night.
Good night. Good night.